Now we would like to start Luncheon Seminar 3, sponsored by Medical Affairs of Gilead Sciences. The chairperson is Professor Motoyuki Otsuka, Chairman, Department of Gastroenterology and Hepatology, Academic Field of Medicine, Density, and Pharmaceutical Sciences, Okayama University. Professor Otsuka, please start.
Hi, hello everyone. Welcome to this luncheon seminar. This seminar is supported by Gilead Science. So in this seminar, Dr. Masayuki Kurosaki will give us a special lecture about HCC and its related issues. Because Dr. Kurosaki is very famous, well known in this field, I will introduce his career just briefly. Dr. Kurosaki is now the Executive Vice President of Musashino Red Cross Hospital and the Director of the Department of Gastroenterology and Hepatology. He graduated from Tokyo Medical and Dental University in 1987, and he obtained a PhD in 1995. From 2010, he is the Director of the Department of Gastroenterology and Hepatology in Musashino Red Cross Hospital, and from 2020, he is an Executive Vice President of Red Cross Hospital. So he has obtained many awards, such as Japan Society of Hepatology Research Award, and so on. So he is a very authority in this field. I believe he will give us a very exciting lecture today. So the title of his today's talk is Recent Topics about Hepatocellular Carcinoma, focusing on risks of hepatitis and advances in therapy. Then, Kurosaki, please start your lecture.
Thank you, Professor Otsuka, for your kind introduction. Good afternoon, members and guests. I would like to talk about HCC, but a special emphasis on the risk of hepatitis B and C. To begin with, this slide shows the changes in the background of liver disease of HCC. During the period of 2014 to 2017, the vast majority of patients were of HCC patients were arised from hepatitis C virus infection and hepatitis B. Although the incidence proportion of patients with HCC with hepatitis C virus infections is decreasing, as you can see on the slide, hepatitis B and C is still the major cause of hepatocellular carcinoma in the country. So this is the agenda today. I would like to talk about hepatitis C and hepatitis B, and just a little bit for hepatocellular carcinoma treatment, because we are expecting to hear a special lecture from Professor Kudo just after this luncheon seminar. To begin with, I would like to talk about hepatitis C. This is the study we've done by using the Markov model. The slide on the left side shows the natural history of hepatitis C infected patients. You can see that the proportion of patients with chronic hepatitis with low fibrosis marker decreases in accordance with the progression of age. However, if the hepatitis C virus is eradicated, the vast majority of patients remain in chronic hepatitis with low FIB-4 index, which means that the eradication of hepatitis C virus inhibits the progression of liver disease in these patients. So every patient should be treated to prevent the progression of liver disease. So the topic is the risk of HCC and how we should survey for HCC after SVR. This is the cost-effectiveness study showing that from the cost-effectiveness point of view, HCC annual rate of 1.5% per year or more is adequate target from the cost-effectiveness threshold. This is a large-scale study showing that patients who had cirrhosis at baseline still has a high rate of HCC even after achieving SVR. The rate of HCC is 2.99% per year. So these patients need surveillance for HCC even after SVR. However, in this study, patients with advanced fibrosis but not cirrhosis, F3 fibrosis, the rate of HCC was only 0.63. So the incidence was below 1.5%. These results suggest that patients with liver cirrhosis should be the target for SCC surveillance, but in patients who do not have cirrhosis, it could be different from surveillance. But this is true. This is the data we have done in patients who achieved SPR. We measured liver stiffness by using MR elastography, and irrespective of the baseline stage of liver fibrosis, you can see the liver stiffness decreases after SPR. On focusing the liver cirrhotic patients, this is the representative cases. The case on the upper panel shows the liver cirrhotic patients who remained cirrhotic even after 1 year after SPR. The patient on the lower panel shows he was liver cirrhotic at baseline, but liver stiffness decreased significantly after SPR, so he is no longer in the cirrhotic status. So baseline cirrhosis is very important. However, probably the liver status, fibrosis status after SBR should be more important. This is the study we've done with using over 300 patients who measured liver stiffness by MR elastography at the timing of SBR. As you can see, patients having high liver stiffness after SBR has a high rate of HCC. It exceeds that cost effectiveness threshold of 1.5% per year. So the repeated measurement of the fibrosis of the liver after SBR may be used to narrow down the patients who needs continuous surveillance for HCC. However, we cannot, not every institute can have a repeated measurement of liver stiffness by MR elastography. Alternative could be the calculation of FIB4 index. It is very easy to calculate. It can be done by every institute. This is the study done with Japanese Red Cross liver study cohort, including more than 3,000 patients who achieved SVR. FIB4 was calculated at the timing of SVR 1 to 3 years after SVR, and we observed the incidence of HCC. You can see that patients having FIB4 index over 3.25 at any time point after SVR had a high rate of HCC exceeding the cost effectiveness threshold of 1.5% per year. This data means that if the patients are in front of the physicians and has a FIB4 index of higher than 3.25, this patient should be monitored for the development of HCC continuously. Apart from this FIB4 index, the serum marker of fibrosis, M2BP-GI, is also identified as a useful marker for the HCC risk even after SVR. This data is from our own institute showing the serum M2BP-GI 1.75 or higher at the timing of SVR was related with the high risk of HCC. When we repeated the measurement of M2BP-GI at the timing of SVR and 1 year after SVR, the data of 1 year SVR was also associated with the high risk of HCC. These fibrosis markers are adopted in the Japanese Society of Hepatology guideline showing that FIB4 after SVR is a predictive marker for HCC development, and also the guideline shows that M2BP-GI after SVR is a useful marker for HCC prediction. So these guidelines define the risk factors focusing on the advanced fibrosis. But what about non-advanced fibrotic patients? This is the study done by Japanese Red Cross liver study cohort, showing that in patients without advanced fibrosis, the incidence of HCC after SVR was 1.1% at the first year, 1.8% at the second year, and 2.9% at 3 years. The incidence is lower than 1.5%, but actually, a small proportion of patients actually develop HCC. Among these patients without advanced fibrosis, we divided patients into groups by using gender and age, and looked for the subgroup of patients who has an HCC risk of more than 1.5% per year. As you can see, male patients with older age, such as age in the 60s, 70s, and 80s, had an annual HCC risk of 1.8, 1.7, 2.9. These patients are not advanced fibrotic patients, but has a risk of HCC of over 1.5 years, which means that these patients should continue to be surveyed for HCC development. So these results suggest that HCC risk after SVR includes older age and advanced fibrosis. So the benefit from SVR is greater if the patients were treated before getting old and before going to the progressive disease. So earlier, the better. So how about the patients who had HCC? I would like to talk about the DAA after curative treatment of HCC. This is a landmark trial which was done in Japan. This is the SURF trial comparing the surgery versus ablation for small HCC. It's a RCT. The median follow-up was about 5 years, which shows that the median recurrence-free survival did not differ between surgery and radiofrequency ablation. But what I want to say is not a comparison of this method. I want to emphasize that the recurrence rate was similarly high even in early stage HCC that was curatively treated by surgery or radiofrequency ablation. This study examined the factors associated with early HCC recurrence and late HCC recurrence. For the late HCC recurrence, the tumor multiple HCC or macroscopic classification of cancer was associated with the later HCC recurrence, but also the hepatitis activity. The background condition of liver was also associated with the high rate of late HCC recurrence. So for hepatitis activity, we can make an intervention such as antiviral therapy. This is the result of our study showing the impact of background liver disease on the long-term prognosis of very early stage HCC after ablation therapy. A prognosis of patients with single HCC less than 2 centimeters treated with ablation were analyzed in terms of background liver disease. Slide on the right side shows the recurrence-free survival. As you can see, patients who achieved SVR has the longest recurrence-free survival, and patients with active SCV infection had the worst recurrence-free survival. Although the background is not matched, this result may suggest that eradication of hepatitis C virus, even after curative treatment for hepatocellular carcinoma, could work to prolong the recurrence-free survival time and also improve survival. We extended our findings to not only to early stage, but those with intermediate stage HCC. This is also the Japanese Red Cross hospital group's work. We compared patients who were treated curatively for HCC and then treated by DAA and compared the recurrence rate and survival rate to the control group who did not receive DAA therapy. If the HCC was within Milan criteria and treated curatively, DAA treatment significantly reduced the recurrence rate and significantly improved the survival rate. So patients within the Milan criteria had the benefit of treating hepatitis C virus infection by DAA. However, in the patients with the intermediate stage exceeding Milan criteria, the recurrence rate was unfortunately not suppressed by DA therapy. However, the overall survival was improved. Therefore, in terms of suppression of recurrence, early stage HCC could be adequate. However, to improve the overall survival, every stage of HCC, it could be a target for DA therapy if the HCC was curatively treated. The prolongation of overall survival may be linked to the improvement of liver function. This is a beautiful figure generated by Professor Toyoda, which shows the importance of RB score in the natural history of liver disease. As you can see, RB score worsens when the patient enters in the cirrhotic stage, and especially RB is very important for the assessment of the prognosis of hepatocellular carcinoma. This is the data of Japanese Medical Hospital Group showing the early data, including only 65 patients. The SVR for the decompensated cirrhotic patients treated with Sofvel was around 90%, and the proportion of patients with impaired liver function had a reversal of liver function after achieving SVR. The number of patients was 65 at this point, but we extended these findings by increasing the number of patients and for a longer observation period. You can see that after achieving SVR, the proportion of patients having good liver function, such as RB grade 1 or modified RB grade 2A, continuously increases, and the number of patients having RB2B or 3 decreases. So this is the most powerful impact of the treatment for improving liver function. I would like to show my own case. She is a female in 80s, and she had a decompensated cirrhosis at baseline, but achieved SVR by Sofvel. She had diuretics, including tolvaptan for ascites. She received BCEA and a synthetic disaccharide for hyperammonemia. After achieving SVR, the albumin level improved and PT activity improved. And as you can see by this MR elastography, liver stiffness was decreasing continuously, and now at the latest time point, she is not cirrhotic anymore, and all medications was discontinued after SVR. Actually, this patient had a small nodule in liver. We were not able to perform ablation because he was decompensated. However, after achieving SVR, we were able to ablate this nodule safely, and there is no recurrence of HCC till now. So this is the impact of improving liver function in cirrhotic patients. Moreover, SVR has an impact on the future systemic therapy for hepatocellular carcinoma. We studied unresectable HCC that was treated with lenvatinib or atezolizumab. When we look into the liver function by background liver disease, such as hepatitis B, C with SVR, C non-SVR, and others, Hep C patients who were SVR has the most improved RB score, most good RB score at baseline. And when we divide SVR patients with and others, as you can see on the Kaplan-Meier curve on the right side, the overall survival tended to be longer in patients who were treated by lenvatinib and in patients who achieved SVR. The trend was the same for atezolizumab plus bevacizumab, which means that Among patients who are not SCC, SVR could be a good uh, mm, could prolong the survival of patients, even if the patient has an unresectable HCC in the future. This is a beautiful data shown by the Hiraoka Sensei Kenichi Byoin, showing that baseline ALB is a predictor of that continuous systemic treatment duration, which means that patients within the good liver function can receive systemic therapy for a longer time. So every patient with Hep C should be treated to prevent SCC or prolong life expectancy even after they develop HCC. So viral expression by antiviral therapy reverses the natural history of hepatitis C, especially improvement of liver function is very important. I would like to go on to the hepatitis B. This is the very important data shown by Korean studies. They investigated the percentage of HCC patients who did not meet the treatment criteria specified in the APASO, SLD, and the EASL guidelines. You can see that 33 or 64% of HCC patients of hepatitis B were outside the treatment recommendation by the guidelines. So treating the patients that is within the guideline is not enough to totally prevent HCC occurrence. This is the ISLD guideline. It's a representative of guideline. I can show you that the indication of NUC treatment is defined by the status of HBe antigen, the level of ALT, and the level of HB DNA. Treatment is recommended in ACLD guidelines if the ALT is elevated 2 times upper limit normal and high HBV DNA. And the treatment is not recommended to those with normal ALT and low HBV DNA. However, there are in between. There is a gray zone that exists. A recent topic is that among gray zone patients, some patients has high risk of HCC. This is data showing that patients within the gray zone, the intermediate indeterminate stage, the HCC incidence was higher compared to the inactive phase. So some patients within the indeterminate gray zone could be a target to be treated. This is the data from China showing that the liver biopsy in gray zone patients revealed that a large proportion of patients within the gray zone actually have inflammation or fibrosis, and taken together, majority of patients in the gray zone has a significant histological disease. So this kind of a histological disease cannot be defined by ALT or DNA. So what we should do, liver stiffness could be one solution. This is the EASL LEH guideline, non-invasive liver assessment treatment algorithm based on liver stiffness. FibroScan is utilized even in patients with hepatitis B with normal ALT if the liver stiffness is above 9 kilopascal. This guideline recommends to consider treatment and screening for viruses and HCC. So if liver stiffness is high, antiviral treatment is recommended regardless of HBe antigen status, ALT, or HBV DNA levels. This could be one solution to find out high-risk patients among gray zone. Professor Gain made an Asian consensus recommendation in resource-limited settings. In hepatitis B infected patients, if the patient has a normal ALT or low HBV DNA levels, what is the factor that should be considered to determine the indication of treatment? The key points of treatment decision was defined in this paper as age over 30 years, liver fibrosis, family history of cirrhosis or HCC or extrahepatic manifestation. So these points should be considered for the treatment decision. With the leadership of Professor Kao from Taiwan, we had a consensus meeting, expert opinion meeting, and defined among gray zone patients, antiviral therapy is recommended if the patient has F2 or A2 or higher. Antiviral therapy could be considered in patients who has a family history of cirrhosis or HCC or extrahepatic involvement, or if the patient's age is over 40 years. So age is an important factor for the determination of the indication of hepatocellular of the nuke treatment to prevent HCC. This is a recent publication in hepatology, probably this month's issue, showing it's a retrospective study led by Professor Bindi. Untreated patients who remained within the indeterminate throughout the follow-up period was compared with the treated patients who are indeterminate before treatment. You can see here that among patients who are 45 years or older, HCC incidence was statistically significantly lower in treated patients compared to untreated patients. However, in younger patients, the difference was not significant. This data may suggest that even though the patients do not fall into the treatment guideline criteria, if the patient is older, it may be possible to suppress the incidence of HCC by treating with nuke. But this is not a prospective study, so this is not a definitive conclusion, but this may be one of the evidences to suggest to treat patients over 45, 40, or 30 to prevent HCC, even though they are not outside of treatment guideline, treatment criteria for the guideline. Another point of view is the integration. Culture genesis from hepatitis B is definitely derived from the active inflammation going to the advanced fibrosis and development of HCC. So inflammation and fibrosis is the major pathway of HCC from hepatitis B virus infection. Another mechanism is said to be the integration into the background liver, which causes a genetic change in the hepatocyte, leading to the development of hepatocellular carcinoma. There are some evidences showing that integration is associated with worse prognosis. This paper shows that the number of HBV integrations was associated with poor prognosis after treatment, curative treatment for HCC. On the other hand, a number of integration correlates with viral load. So the persistence of high viral load may be associated with the high number of integration. This study done a paired biopsy before entecavir and after entecavir. They reveal that the number of HBV integrations decreased with only 48 weeks of treatment with entecavir. So nuke treatment may work to decrease the number of integrations. This is another independent study showing that the same result. They examined 190 patients who had a high HBV DNA but minimally raised serum ALT. TDF was placebo was given, it's a RCT, and paired biopsy was obtained 3 years later. You can see the log expressed integrants on the figure on the right side. You can see that is a decrease of the number of HBV integration after treatment with TDF for 3 years. So we cannot make a definite conclusion, but there are two pathways of HCC caused by hepatitis B virus. One is the inflammation and fibrosis progression, and one is the integration. We usually recognize that the HCC inhibition by antiviral treatment is the prevention of inflammation and fibrosis progression. However, alternative mechanism may be the prevention or the inhibition of hepatitis B integration. But this is just a speculation. We do not have a solid data to prove that the decrease of integrations actually proved to be proved to increase the survival rate or suppress the HCC development. It's a future question. I would like to talk about the residual risk of HCC after NUC. This is the landmark data from Japan Toranomon Hospital. Professor Hosaka revealed that entecavir reduced the incidence of HCC to about 25%. There are many scores, HCC prediction risk scores after NUC therapy, represented by page B, modified page B, APA B, real B, AMAP. Every scores include age, gender, or platelets that represent the grade of liver fibrosis. So older age, male gender, and low platelet count or liver fibrosis are very important predictors of HCC in hepatitis B patients who receive NUCs. This is the validation study done by our own hospital and the Japanese Red Cross Hospital group. We divided the patients who received NUCs according to this page B. Page B is constituted of age, gender, and platelets. And the result was the same as the original report. Patients having a high-risk page B group had a high risk of HCC even after NUC treatment. And this was also true for the Japanese Red Cross Hospital cohort, showing that patients with high page B scores had a high rate of HCC. So page B is very easy to calculate score, and we can utilize this score to predict the occurrence of HCC even after the introduction of NUC treatment. This is a study using over 2,000 patients in Japanese Red Cross cohort. We calculated the page B, modified page B, AMAP, APA B, real B in at baseline and 1 year after introducing NUC. You can see the AUROC was similar between these scores, not so different. But what I want to say is that the AUROC improved if the score was made after 1 year of treatment of NUCs. You can see that for the every risk score, there is an improvement in AUROC. So page B was originally reported to be calculated at baseline, but according to this data, probably repeated measurement of these risk scores may serve as a good predictor of HCC among patients who are on NUC treatment. I go back to this slide again, and you can see that various scores utilize age, sex, platelet, albumin, bilirubin, AFP, alcohol, cirrhosis, or diabetes, but no score includes ALT, especially post-treatment ALT. This is the very beautiful data reported by Korean single-center study. They studied over 4,000 patients treated with entecavir or TDF. The definition of normal ALT was lower than 35 in males and 25 in females. They extracted over 3,000 subjects without fatty liver and analyzed for the development of HCC stratified by the timing of ALT normalization. You can see the annual rate of HCC development was lowest in patients who had ALT normalization within 6 months of treatment. The HCC rate was highest among patients who did not have ALT normalization within 24 months of treatment. The result was same if the patients were extracted according to the criteria that HBV DNA was negative within 2 years. So these patients had a good viral response, but still, patients who did not have ALT normalization within 24 months had the highest rate of HCC development. These data indicates that ALT after giving NUCs and the timing of the timing to the normalization of ALT is very important for the future prediction of HCC development. So the definition of a normal ALT was 35 in males and 25 in males. Is this enough? This is a clinical question. So we searched for the optimal threshold of ALT after introduction of NUC to predict the future development of HCC. The number of cohort was 413. The factors that was associated with HCC development after NUC was male gender, lower platelet count, and ALT greater than 21. Greater than or equal to 21 at 1 year after NUC. It was not 30, it was not 40, it was 20. As you can see on the Kaplan-Meier curve on the right side, patients having ALT greater than 21 at 1 year after NUC treatment had a higher rate of HCC. So the target ALT that we should recognize after NUC therapy for HCC prevention is below 20. Even though the patient has a low ALT around 30 or 40, the patient still has a risk of developing HCC in the future. You can see on the slide that there is no score that includes hepatic steatosis or fatty liver. This is the study we published this year. We divided patients into those with advanced fibrosis or those with fatty liver. You can see all of these patients are on NUC therapy. The highest rate of HCC was observed in patients with advanced fibrosis with fatty liver. The fatty liver was diagnosed by using ultrasonography. Among these patients, the HCC incidence was as high as 13% 1 year, 23.8% 3 years, and 23.8% at 5 years. So high HCC risk in HBV patients under NUC therapy is the advanced fibrosis with fatty liver. Is this true? There is a meta-analysis. There is various reports analyzing the effect of fatty liver on the prognosis in hepatitis B. This is a meta-analysis showing the result as the hazard odds ratio was 1.59 worse if the hepatic steatosis exists in patients with hepatitis B virus. The meta-analysis shows that the fatty liver is not so good for hepatitis B patients for future development of HCC, but you can see that the odds varies among studies. So is this also true? This study shows more detailed analysis. This study counted the number of metabolic factors such as obesity, diabetes, impaired fasting glucose, hyper-TG, hypercholesterolemia, and hyperpressure in terms of HCC risk. You can see on the left side that patients having 3 or more metabolic risk factors had the highest incidence of HCC. And when patients were divided into non-obese, non-diabetics, this group had the lowest risk of HCC. And among patients obese or diabetic and having more than 3 metabolic risk factors had the highest rate of HCC. So apart from treating hepatitis B virus and suppress viral replication, probably the metabolic factors could be a target to treat to further reduce the risk of HCC in these patients. A biological goal of nuke treatment for HCC prevention. Obviously, keep the HBV DNA undetectable is the aim of the nuke treatment and should be the hallmark for the suppression of HCC. Actually, in our cohort of patients, HBV DNA detectable patients, whether persistently or intermittently detectable or unquantifiable but detectable, these patients had a higher risk of HCC compared to those with undetectable, continuously undetectable HBV DNA. So we should aim to keep the patient's HBV DNA continuously undetectable. For this point of view, we analyzed the patients who received entecavir and switched to TAF. Only a small number of patients, but we divided into the patients into complete virological response. The HBV DNA is continuously undetectable, and low-level viremia, who has a viremia intermittently positive, or the occasional HBV DNA, occasional. This one, yellow one, is occasional, and LLB is the red one. You can see among patients with occasional detectable when treated by entecavir, 15 out of 22 patients went on to CVR after changing to TAF, and among LLB, 3 out of 8 patients entered the complete viral response. The rate of CVR was 33% when they were treated with entecavir, but after switching, it improved to 68.9%. So low-level viremia or intermittent emergence of HBV DNA is not enough to suppress fully the incidence of HCC. So we should consider adding another nukes or switching to another nukes to achieve continuous HBV DNA undetectability. This is the data from Hong Kong group showing that patients who achieved HBs antigen negative, the rate of HCC is very low. However, the majority of patients cannot achieve HBs antigen negativity. So we need another marker to assess the risk of HCC. One of them is a core-related antigen. This is the data presented by Tramon Hospital, Professor Hosaka, showing that in HBe antigen positive patients, core-related antigen over 4.9 at 1 year after initiation of a nuke was associated with SCC, and 4.4 log in HBe antigen negative patients at 1 year after initiation of nuke was associated with SCC. From our own cohort, the cutoff value was 4.0. But anyway, a positive core-related antigen, especially the high-level core-related antigen, is related to the higher incidence of SCC. Nowadays, we have a more high-sensitive core-related antigens, and according to the analysis of Professor Hosaka, the actual threshold that we should aim is below 2.1. Among these patients, the SCC was not detected. So when treating patients with nukes, HBV DNA negativity is the first, core-related antigen reduction to undetectability is the second, and S antigen seroconversion is the final goal. I would like to talk just a little bit advances in the treatment of SCC for cure. First, lenvatinib. Among intermediate stage of SCC, some could be treated curatively by case, but some are not. One criteria is the tumor burden, such as up to 7 out. This is the data done by the Japanese Red Cross Liver Study Group. We included over 300 patients who were treated with Lemba. And as you can see, among BCLC stage B patients treated to lenvatinib as a first line and had a good liver function, median OS was 25 months and median PFS was 12.3 months. So the data was pretty good. However, as you know, we have published 2 papers, but the efficacy of lenvatinib is dose dependent. Who has a dose reduction within the first 4 years or later has a decreased efficacy. So this is one of the characteristic of the lenvatinib and one of the drawback of this drug. This is a representative case who had a taste unsuitable HCC and treated by lenvatinib with a good response. However, he is an 80-year-old male and could not tolerate the high dose of lenvatinib, and the dose was reduced and the blood flow reappeared. But we have another alternative. We can give a taste to have a complete response. So if the patients could not tolerate high dose of lenvatinib, local regional therapy could assist the patient's tumor response. So we should consider the addition of TACE in patients who cannot tolerate high dose of lenvatinib. So this is the data from Hiroshima University, I think. They compared the lenvatinib treated patients versus lenvatinib plus TACE patients in BCLC stage B. It's a propensity score matched analysis. You can see the progression-free survival or overall survival was better in patients who were treated by lenvatinib followed by TACE. So this kind of addition of local regional therapy could be alternative to the simple TACE, and len-TACE may increase the chance of curativity. I'd like to talk about a little bit about atezolizumab. This is the IMbrave 150 showing that OS for atezolizumab was 19 months and PFS was 6.9 months. This is our real world data in Musashino Records Hospital. The overall survival for the patients who were treated with atezolizumab as a first line was 24 months, and PFS was 8.2 months, so similar to IMbrave 150. Prediction of the response to atezolizumab is very difficult before initiating the treatment. However, we can estimate that the patient could have a long progression-free survival if the AFP decreases deeply after initiation of the treatment. This is done by the Japanese Red Cross Hospital cohort. You can see that the deeper the AFP decreases, the longer the progression-free survival is. So deep decrease of AFP means the longer progression-free survival could be expected in these patients. This data was presented yesterday by Professor Yasu in our hospital. We define durable response to atezolizumab as those who received atezolizumab for 6 months, more than 6 months, and maintained CR/PRSD for more than 3 months. For the first-line treated patients, the durable response was 40%, and second line or later, the durable response was 18%. When we look into the overall survival in those with durable response and without durable response, we can see that the overall survival is better in those who had a durable response, irrespective of the first-line treated or second-line or later treated patients. However, you can see that is a drop of survival even in durable responders. So we have to do something to improve the prognosis of these patients. And also, patients without durable response, we have to do something to improve their survival. For the responders, addition of local regional therapy could improve the patient's survival. This is the representative case showing that the atezolizumab, there was a response, and addition of TACE led to the final complete response and drug-free. This patient was in BCLC stage C. He had a multiple HCC with bile duct invasion, And first-line treatment, atezolizumab was given, and with a good response, and convergence surgery was performed, and then achieved CR plus free. So this kind of conversion treatment or addition of local regional treatment for responders could improve the survival. This is the 9 out of 84 patients treated with atezolizumab as first line in the hospital achieved cancer-free, and their prognosis is very good. So consideration of surgery or TACE or ablation, especially in those with response to treatment, is very important to improve the prognosis of the patients. So what should we do for the non-responders? We have many drugs of choice for the patients who did not respond to atezolizumab. This is the study, nationwide study reported by Professor Saoka, which is called the Heritage Stage. It's a registry study of the DA-treated patients within our country. For the atezolizumab, 368 patients were registered who were treated by atezolizumab for the first line, and for the second line treatment, most frequently used therapy was lenvatinib. This is the detailed data of the second line drugs, but I would like to just extract atezolizumab data. Among patients who were treated by atezolizumab for the first line, the most frequently used second line treatment was lenvatinib. 72 patients were treated by lenvatinib after atezolizumab. The response was reported in 47 patients, showing that the response rate was around 15, and the disease control rate was around 80. This is the national data. So we looked into our own data. 23 patients were treated by atezolizumab first and lenvatinib second. For the response rate, overall response rate was 70%, and disease control rate was 65.2%. We looked into the degree of proteinuria and the response, and we found that patients who do not have severe proteinuria had higher ORR and higher DCR. And also the progression-free survival was longer in these patients who did not have high grade of proteinuria. So the proteinuria could be one of the predictor of response to lenvatinib after atezolizumab. So this is a summary of my presentation today. For hepatitis C, we have to assess the risk of HCC after SVR. Fibrosis such as FIB4 or M2-BPGI is a hallmark of a high risk of HCC, and also age and gender. A DA after HCC cure should be introduced to reduce the recurrence and improve OS. The most prominent impact of DA treatment in hepatitis C is the improvement of ALB. It has a positive impact on the future treatment option of HCC. For hepatitis B, of course, the indication of NUC is based on ALT and HBV DNA. However, there is a gray zone. Fibrosis or family history of HCC or age or HBV integration may be another factor that could be associated with the development of HCC, and we should consider these factors when treating patients. The risk of HCC after NUC, there is a numerous scoring. We can utilize it. However, what is not included in the scoring is the treatment ALT levels after treatment. ALT over 20, steatotic liver, or metabolic factors could be another risk of HCC even after NUC. And these things should be considered in individualizing the treatment or follow-up of patients on NUCs. Biological goal of NUC is, of course, the negativity of HBV DNA and HBs antigen loss is the ultimate goal. However, the reduction in the serum level of core-related antigen may be the good predictive marker for the risk of HCC, residual risk in hepatitis B. For the advancement in treatment of HCC for cure, I'm expecting a lecture from Professor Kudo, but just briefly, lenvatinib plus TACE could be a curative treatment option for intermediate stage HCC, and for the atezolizumab, even in the responders, conversion by using surgery ablation or TACE could be used to further improve the prognosis. And for the sequential treatment for PD, we do not have many evidences yet, but lenvatinib seems a good option. These are my collaborators, and thank you for your attention.
Thank you very much, Dr. Kurosaki, for your very clear and logical presentation, as always. May I take questions from the audience, Dr. Kurosaki? Okay. So, are there any comments or questions from the audience? May I ask one question? So you said, you mentioned metabolic factors and the strategic factors are related with the recurrence of HCC after NUC therapy in BHCC. So how about in case of HCV-related HCC?
Thank you for your question. For hepatitis C, there is various reports on the effect of taking alcohol, diabetes, obesity, and fatty liver. And vast majority of reports have emphasized the impact of these metabolic factors on the development of HCC, especially the later phase of observation. You know, the development of HCC just after SVR is closely associated factors such as fibrosis or elevated alpha-fetoprotein, but later on, the impact of these factors decreases and the impact of metabolic factors increases. So we have to have a continuous monitoring of patients who have metabolic factors, even in hepatitis C SVR patients and hepatitis B on NUC patients.
Thank you. So another questions or comments? Dr. Kato, please.
Kurosaki Sensei, thank you for your excellent presentation, and I'm very impressed by the data you have shown that atezolizumab is the same efficacy median OS as the first line or second line or later, more than 20 months. And if it is true, atezolizumab, usually first line, second line, or later treatment is less effective than first line treatment. But from your data, we should use atezolizumab not for first line, but as second line or later. It is right?
Thank you for your question. Maybe I was too fast to move on to the next slide, but our data actually shows that the median OS or PFS is better for the patients who are treated by first line. And the data is a little bit worse in patients who are treated on the second line. So I believe that in eligible patients, atezolizumab should be given as a first line. But, you know, patients who are already on NUCs, we have many patients already on TKIs, and if they have a progression, I think atezolizumab could be a choice of treatment in these patients. But in treatment naive patients, and we have to select what regimen to give to these patients. If these patients are eligible for treatment, atezolizumab should be given as a first line.
Thank you.
Thank you very much. Okay.
Thank you for your instructive lecture. It is interesting that heterogeneous localization, ER elastography demonstrates that heterogeneous localization is liver stiffness. Is that heterogeneous localization can predict the site of the HCV occurrence after the SPR or not?
Thank you for your important question. We usually measure liver stiffness with different site and average them to represent the stiffness of the patient. Your question is that the degree of the risk of HCC differs between the site of the liver, and we do not have a definite answer. I don't think that HCC is arises from the most high level of stiffness. The stiffness, localized stiffness is, I think the localized stiffness is not a predictor of HCC at that site, but totally speaking, if the patient had an average level of high liver stiffness, it is true that they have a high risk of HCC, but the localized high stiffness is not a predictor of HCC at that site.
Thank you.
Yes. Ah, 松先生。
17 years old matter in Tokyo, I saw the patient. Then after I moved 15 years, I constantly look at the patients. And then every single cases we measure, or not every single cases, maybe twice a year, we measure the fatigue change and stiffness by elastographies. And then this time we present the data by showing the 4 groups, little fibrosis, little fatigue change, little fibrosis, more fatigue change, and 4 groups divided. And it turned out, if you have a more fatty change, DPM higher 260, gonna get less cancers. In other words, if you have a same degree of fibrosis, more fatty change in only 5% got cancer, comparing to the same fibrosis and the little fatty change, 21%. So seems right, and the same apply for the group with little fibrosis, more fatty change, less cancer occurrence. Seems right, people are talking about burnout. That cannot be proved because if there is a group with a lot of fatty change, little fibrosis, then in 5 years' time, if move from this group 2 to 3, can be burnout. I couldn't prove it because we are consecutively following this patient. So in essence, maybe if you maintain, keep the fat, maybe you are suppressing the cancers.
Thank you for your comment. Your comment is based on your own data, so it's very surprising, but there is pros and cons on the effect of liver fat content on the future development of HCC in the area of hepatitis B, I think. And the one hypothesis is that, as you said, the fatty liver itself is not a causative or risk factor for HCC. However, I think that the causes of fatty liver, such as diabetes, obesity, and the metabolic factors, those factors are repeatedly proven to be a factor for the promotion of risk of HCC. So not just a fatty liver, but those metabolic factors should be considered for the assessment.
Yeah, that's totally agree, because if you introduce those metabolic things like diabetes, it's a totally complicated situation. So not the pure fatty change. So in the case of the pure fatty change, maybe really suppressing the cancer. That's what I want to say that. Yes.
Yes, I think you may be true, but we have to be cautious about this.
Yeah, thank you very much. So we are running short of time. So thank you again, Dr. Kurosaki, for your nice presentation. So we are ending this session.
Thank you very much, Professor Otsuka and Professor Kurosaki.